possible to ensure that breast cancer early detection is a reality. The Jordan Breast Cancer Program is a national program led and supported by the King Hussein Cancer Foundation and Center in close collaboration with the Ministry of Health. Our main mandate is downstaging of breast cancer from late stages to early stages. Therefore, we work on three main pillars. The first one is ensuring availability and access to quality early detection services. Second, to raise awareness and change social behaviors to increase demand on early detection. And third, to create an enabling environment for early detection through advocacy, policy, and research, including working on building the capacity of health cadres and early detection field. However, these efforts will not be complete and fruitful without the presence of people like you, the people who are on the front lines, who do the real work to fight this disease. Today, it's my pleasure to welcome Dr. Mike Ulysses to our first session entitled as Approach to Mammogram Beyond the Basics. Dr. Mike is a fellow of the American College of Radiologists. He's a breast radiologist at the Centers of Diagnostic Imaging, now Reyes Radiology, with offices in Seattle and surrounding areas. Dr. Ulysses is a research and teaching professor of radiology at the University of Texas, and he was the director of breast imaging at the University of Texas Southwestern Medical Center and Kirkland Memorial Hospital in Dallas. Over the week, we will have more colleagues for Dr. Mike. We will have Dr. Pamela Otto and Dr. Tom Stavros, who are both also fellows of the American College of Radiology. Our session will last for 1 hour, and we will open the floor for questions and answers at the end. You can ask questions through 3 different ways. First, you can send it to us over the chat, or you can send it over Q&A, or you can raise your hand, and then the Jordan Breast Cancer Program team will give you an access to open your mic and to ask your question directly to Dr. Mike. Thank you very much. And again, it's our pleasure to have you all. أهلا وسهلا فيكم جميعا وشكرا لحضوركم. Dr. Mike, the floor is yours. وأهلا وسهلا فيك أيضا as you speak Arabic. So أهلا وسهلا. We are so happy.
شكرا. أنا ما أتكلم العربية كثيرا بس شوي كلمات. السلام عليكم يا شباب. مساء الخير. And unfortunately, I have to switch to English. I'm sorry. Can you see my screen?
Yes, doctor.
Okay, it should say welcome and thank you. So yes, as Reem said, I'm going to talk today about approach to a mammogram and something more than just the basics of look for symmetry in both breasts and check the MLOs, check for calcium. I want to try to talk about a few other things that I think will make us all a little bit better when we approach mammography. I am a retired professor from the medical school in Dallas, but I still have a teaching and research appointment. And I'm working on a few projects. So I'm some private practice center near Seattle, Washington, and I go there 1 to 2 weeks a month to see patients. And CDI recently got, we were changed the name to Reyes Radiology. Why it's all important, the outline for my talk today is why it's all important. And Reem, I think already told you 44,000 cases of breast cancer in the Middle East, and we have about the same in the United States. Strategies to reduce false negative mammograms. False negative mammogram is just our miss rate in mammography. I think it makes us feel better if we say false negative instead of we missed the breast cancer. But and sometimes it's not that you miss it, it's very subtle on the old mammogram, on the previous mammogram, but sometimes it's not. And the difficult thing about doing mammography is you see your misses from last year or the year before, and sometimes it's difficult to understand where your brain was, where your eyes were last year when you were reading the mammogram. Talk about screening versus diagnosis, and then I want to talk about a more comprehensive approach. The role of ultrasound in the United States, medical legal things are very important. I don't know what the legal environment is in Jordan, but in the United States, it's very difficult sometimes for doctors because we have a lot of attorneys, a lot of lawyers looking at us to see if we missed a breast cancer. And doctors, some are very worried in the US about getting sued and losing everything. Breast cancer in the United States is the most common cancer, and in the Middle East, most feared cancer, probably also in the United States and in the Middle East for many reasons. And it's in the United States anyway, it's scrutinized by the medical, by the legal community, the lawyers. We don't really know what causes breast cancer. We know that some of them are hereditary. There are BRCA1, BRCA2 genes and some other genetic influences, but there are probably a lot more environmental influences that we cannot control for. And it's also difficult to study from a research environment, from a true case-controlled research study. But there are, especially now, more than 30 or 40 years ago, hormones in meat, dietary fat, and things like that. We also know, though, that 75% of women who get breast cancer have no identifiable risk. So to try to based on risk factors doesn't make sense. It makes sense if you're high risk, because if you're high risk, we can do other studies. We might do a screening ultrasound, or we might do a breast MRI. But for most women, about 75% of women, it seems to be just a random event that happens to some women and doesn't happen to other women. So in the United States, what's the most important thing to do when you see breast cancer on a mammogram? I teach residents and fellows at the medical school. They sit next to me and we read the mammograms together. And I say, if you see one cancer on a mammogram, what's the next thing you're supposed to do? And of course they say, well, if you see one cancer, you're supposed to look for another. And I say, no, that's the second most important thing to do. The first most important thing to do is to look at the report from last year and see if your name is on the bottom of last year's report, because everybody else is going to be looking at that too. And then if you see one cancer, you look for another. This is a photograph I took from Dallas, Texas, when I was director of the cancer center at the medical school in Dallas. I would go across a highway, a road, and maybe 200,000 or 300,000 people drive on this road north or south every day, twice a day. They go 200,000 go down in the morning, 200,000 come back at night to go home. And this is the attorney's building, and that's a shark. So an attorney in the United States, when he says he's a shark, he says he goes after everybody. Now, he specializes in traffic accidents, not in medical malpractice. The medical malpractice guy is around the corner. He doesn't have a shark on his roof, but I think he has one in his heart. Okay, so anyway, that's why I say to look at last year's film and see if your name was on it. Now, there's a very good study that was done over 20 years ago in the United States, and it was a study that was supposed to look for CAD, see if CAD, computer-aided detection, would help us on a mammogram. But I think the best part of this study was, I got trouble with my mouse. Oh, let me go back. The best part of this study was that this woman, Dr. Warren Berhana, Linda Warren Berhana, she went out and got over 1,000 mammograms, and she found the ones from the previous year, last year's mammogram, and they reviewed just the last year's mammogram, not the new mammogram that had cancer, but last year's mammogram. And a panel of 5 radiologists, HMSA, okay, 5 radiologists found that in retrospect, 67% of the time, the cancers were visible on last year's mammogram. And 27% of the time, they said, look, somebody should have noticed this last year. So almost a third of the time, more than a quarter of the time, 27%, they said, you should have noticed this last year. And so this study, even though it was a good study for CAD, it was a better study for analyzing the radiology miss rate or false negative rate in mammography. It does happen. And we know that breast cancer has a natural history. If that woman doesn't get a mammogram on a regular basis, or if she gets a mammogram, but we fail to diagnose the breast cancer on the mammogram, it will continue to grow. What's going on here? My mouse is acting up. I'm sorry. The breast cancer will continue to grow. Sooner or later, it will become palpable. Okay. She will begin to feel it. And the woman sometimes doesn't come in when she first feels the lump. Maybe she has a lot to do, other things, taking care of her family. Maybe she had a girlfriend down the street who had a cyst, and the cyst went away on its own, so she's hoping this will go away on its own. And we might not see this lump until it's a bigger lump, when it's maybe late invasive, and it might be axillary node positive at that time. The trouble is, we don't do women any good by picking up a breast cancer that's already palpable. If you can already feel it, we can help her through an important time in her life. We can do a needle biopsy. We can be sympathetic. We can take care of her. But where we do the best good for the woman is if we can pick up that cancer before she can feel it. When the newest small 1 centimeter mass or 1 centimeter asymmetry on a mammogram, okay, before it's something that she can feel, or when the calcifications first become visible. And if we are picking up these days 3, 4, 5 millimeter groupings of calcifications, and we can make this a very minor problem in the woman's life and not a major disaster up over here. And so that's our goal when we look at mammography. It's really the hunt for cancer. And the hunt generally begins with a mammogram, not with a physical exam every year by your doctor. Because again, we want to identify the cancers before you can feel them, okay? So I think, what's the most important thing we do in breast imaging? Is it that we do biopsies? Is that we talk to patients? Is that we do diagnostic recalls? I think the most thing we do is screening mammography, because that's where we can make the most difference in this woman's life, where we can pick up the cancer when it's small, not when it's big. And so if you believe, or if you agree with me that the most important thing we do in breast imaging is screening mammography, then we should treat it as important. In my centers, when we go into the screening room, we might have to read 50 or 60 screens in a batch at a time. We turn on a red light, we close the door, we read with an assistant, and we are not allowed to be disturbed for any reason. We're not allowed to be disturbed for a phone call, or if a doctor wants a consult, or if something else is going on. Our job is to focus on every mammogram to try to find that small little breast cancer. And the only way to do it well is to not have distractions, because there are a lot of distractions that can happen when we are trying to find that breast cancer. So again, one of the things I do, this is an old picture of me years ago, decades ago, but I read with an assistant, and she does the computer work or she does the paperwork, okay? It's important because then I can stay focused and I'm not getting distracted by having to type things in or do a lot of other stuff, okay? And of course, we read in the dark in the old days, but I still try to do it today, okay? Remember that there's a difference between screening and diagnosis. And the difference generally is not the mammogram. The mammogram initially is the same, 4-view mammogram. The difference between screening and diagnosis to me is what I am thinking, the frame of my brain, the frame of my mind, when I'm reading screening mammography is different than the frame of my mind when I'm reading diagnostic or when I'm working in the diagnostic clinic. In the diagnostic clinic, I'm trying to solve a problem. In the screening clinic, I'm trying to find a problem. And there's a big difference in how you approach that mammogram, because you're going in a batch reading and you're going from work list to work list, from screen to screen, and you're looking for a small footprint of breast cancer. The thing about it is, if you're reading 100 mammograms, breast cancer is actually pretty rare on a mammogram. Maybe 1 in 250, 1 in 200 mammograms will have breast cancer. So you have to keep up a very high level of worry, of concern, of suspicion. You have to keep up a high level of suspicion on every mammogram to find breast cancer, when breast cancer is pretty rare on the mammogram. So one of the things you notice is your brain starts to think of other things. You'll read 10 mammograms and pretty soon you're thinking about your automobile. Did I change the oil, or do I need to get maintenance? Or am I supposed to pick up my children after school, or is my wife going to pick up my children after school? Or, did I leave the garage door open when I drove out of my house, or something like that? You're thinking of other things pretty soon, and you're not focusing truly on the mammogram. And those are the things that you have to do. You have to keep up your focus on every mammogram and not start letting your brain drift away. So in the screening, we have 2 assessments, maybe 3. BI-RADS 0, BI-RADS 1, 2. So either the mammogram is normal or it's a recall. We don't sit there and say, oh, I might think that this in the left breast is a cancer, but I don't call it a BI-RADS 4 or a 5. I call it a 0, so that the woman can come back. We can go through the diagnostic evaluation. I can show her her films, let her know what's going on. And maybe it turns out to be normal. Maybe it doesn't turn out to be normal. But in the screening room, we only use BI-RADS 0 or 1 or 2, generally 0 or 1. So again, stay focused on every mammogram. And I've come up, I had some private practices in Dallas, and I was reading. For 5 years, I read over 20,000 mammograms a year. One year, I read over 24,000 mammograms. And the difficult thing about that is not the volume of work, okay? It's actually doable in a good, efficient system. The brutal thing is that if you read 24,000 mammograms, you will occasionally miss a cancer. And I see all my own misses, and I have to go back and look at last year's film and figure out why I didn't notice that cancer. And I've come up with ways in doing that help me stay focused, because that's the big thing, is to stay focused. Okay, and what we're talking about is perception. You have to be able to perceive. You have to be able to notice the footprint of breast cancer on the mammogram. Okay, so you need an organized pattern of review. It's very easy to read a mammogram when the breast density is like this, right? Because normal tissue on a mammogram is white, breast cancer on a mammogram is white. We can tell the good white from the bad white on this mammogram because it's got so much low density. But it becomes more difficult on a mammogram like this, where you have a lot of natural background white. And if you have a small cancer and it's developing here on this medial aspect posteriorly, probably it will be easier to see. But if it's developing down over here, it'll be much more difficult to see. Okay, so one of the things I like to do is I like to play what I call the second chance game. If I gave you a mammogram and I said, Mohammed, you read this mammogram last year or 6 months ago. You read this mammogram 6 months ago. Do you want to take a look at it again? You know what I'm talking about, right? how long will it take you to find that small breast cancer that you missed 6 months ago when you see this mammogram again? Because now you're looking at it with a different set of mind. You're like, oh my gosh, Mike is trying to tell me that I missed a cancer. And your eyes will probably go right to it. Boom, right to it. So what I like to do on every mammogram I do is I pretend like it's an attorney, like a lawyer, bringing me a mammogram saying, can you review this study for me? When I was director of the cancer center at the med school, I would get a lot of attorneys coming and bringing me mammograms because they wanted to sue other doctors or they wanted to defend other doctors. And they would bring me the mammograms to review and see what I thought about the previous mammogram or the current mammogram. And so I learned that what my eyes would do is they would haphazardly, they would go all around the mammogram very quickly in maybe 2 or 3 seconds. And it was almost like it was disorganized. But I think what my eyes were doing is they were going to places on the mammogram where I had missed breast cancers in the last 15 years. So I think about every time I see a missed cancer, it gets burned into my brain of why did I miss it? How did I miss it? Where is it located on the mammogram? And so I would start to read mammograms where my eyes were going probably to places that I missed cancers before. And then I would go through my organized pattern of review. And we'll talk about that in a minute. So the first thing I like to do is I like to bring up a mammogram and say, where's the cancer? Where did I miss a cancer? Or where did my doctor who works with me, my colleague, where did he or she miss a cancer last year? So the first thing I do is I pretend like it's an attorney bringing me a set of films. So if you look at this mammogram over here, is there anything that catches your eye right away? There's a missed cancer on this mammogram. Where is it? And I know we don't have, if anybody can talk, that's fine. Or I don't see a chat right now that if anybody answers this, but you can type, is it in the right or the left? So it's this area right over here. If you look at the parenchymal cone here versus here, how it's nice and smooth on the left side, and it's not so smooth on the right side. Okay, that was called normal. All right, if you take a look at this mammogram, I don't know how well it's projecting. Yeah, let me go back. So the next mammogram, I'm going to bring up another mammogram. Where's the missed cancer? Okay. Does anybody see anything? I don't know how well it's projecting, but we're going to take a look at the right breast right here in the axillary tail region, right up over here. You see that? That's the axillary tail region. Little tiny cancer that was not noticed a year prior. These are old analog mammograms because this is where I learned how to do this. 20 years ago, I was thinking, man, where is my brain? How can I do a better job? And so these are the original mammograms that I started to come up with this idea. Then I go through my organized pattern. The sunrise sign is something I do because it checks for symmetry. If you look at this mammogram over here, you can see the lymph nodes. And I do it in my mind's eye. I pretend like I'm just going down the top of the mammogram. I'm bringing some blackened film straight down, and I'm looking for a rising sun. So I come down, I come down, I come down, I come down. Do you see a rising sun over here? You see that sunrise sign? Okay, a lot of people say, well, that's probably just a lymph node. It wasn't. Okay, I look for the sunrise sign. See how that sun is rising? It's rising on the right side, but not the left side. Rising sun. Okay, the sunrise sign. Check the regions right behind the nipple. It's very easy to miss the subareolar regions. Okay, you have a mammogram over here, and it is maybe heterogeneously dense. It's certainly got some dense breast tissue, but it's very easy to not notice in the background of dense breast tissue that there's a round mass over here. Now you might see it more easily with 3D, and that's fine, but check the subareolar regions because little cancers can hide in the subareolar regions very easily. Remember, all roads lead to Rome. Everything is coming to the nipple areolar complex right behind it. and it gets very dense there sometimes, and you have to look for things that might be hiding there. Okay, little cancer. Okay, check the axilla. Many people forget to check the edges of the film, okay? Many people forget to check the edges of the film. So look in the axilla, make sure you consciously look in the axilla and check the edges of the film all around, okay? Both sides. Take a look at this film, okay? Does this film have enough axillary tissue for you to check the edges? You've got to do a technical repeat on this film because there's not enough tissue over there. So you have to notice the quality of the images as well. And we'll talk about that in a minute. Then the other thing I like to do is before I finish, I go once more and I check the whitest area of the film, because normal tissue on a mammogram is white, breast cancer on a mammogram is white. We have to tell the good white from the bad white. And so some cancer is white. So before I finish the study, I always check the whitest area of the film. This is again easy because this is low density breast tissue, okay? But check the whitest area regardless. And then instead of looking for calcium, I look for lint or dust. A doctor named Ed Sickles, he's a very well-known doctor in the United States, really around the world. He taught me this probably 20, 25 years ago. Every mammogram has some kind of speck of white on it, like lint, dust, something there, a little piece of calcium from something that's benign. Look for some kind of lint, dust, or speck of white on a mammogram as you're going through it. On digital now, you can read with the magnification views, the super magnification views. It becomes easier to see calcifications. But I have to actively, you read a mammogram and you can go very quickly and you can think you look for calcium, but you didn't really look for the calcium. And so on this mammogram, it's an old analog film because this is where I first started to do it. Off artifact, there's some lint and dust on it, but then in the background of that, there were these calcifications, and this turned out to be a string of DCIS. So I like to also use CAD. I use it appropriately. Doesn't help me very often, almost never, but every now and then it still helps me, okay? And I like 3D, I like tomosynthesis, okay, DBT. It takes longer to read with DBT, but it reduces your recall rate and increases your cancer detection rate. Again, it certainly takes more time, but I think that it's worth it because there's a lot of medical devices that look for sensitivity and specificity. But usually, if you want more sensitivity, you have to have less specificity. Or if you want more specificity, you have to have less sensitivity. There are very few medical devices that will increase sensitivity and specificity at the same time. Very few, a couple, but not very many. And DBT has been shown to be one of them. And so I do like it, even though it takes more time. So I tell the residents, if you're super busy, just read the MLOs, and if they're okay, go on to the next case. And it's a joke, okay? It's not real. You can't do that. But most people laugh when I say that. But this one resident thought I was serious, and his eyes got really big. And he said, "Is this doctor crazy? He's my supervising faculty." And I told him, I said, "It's a joke, okay?" I tell my kids I'm the funniest guy that I know, and everybody who works for me agrees. Anyway, so now I'm testing you. Testing, 1, 2, 3. Testing, 1, 2, 3. I'm going to show you a cancer, and you have to a mammogram, and you have to tell me where the cancer is. Okay. All right. Testing, 1, 2, 3. This is a mammogram with cancer on it. Where's the cancer? Okay. Is it on the left or the right? Okay. If you said it's on the right, you're wrong. Well, that's a cancer, but that's not where the radiologist missed the cancer. He didn't miss the cancer over here. He missed the cancer over here on the other side. Okay. See that right over there? Yeah. the radiologist jumped on this cancer with both feet and said, oh my gosh, we have to do something. And in the meantime, failed to read the rest of the mammogram and failed to notice the cancer on the left side right over here. What happened? Okay, it's tunnel vision. Okay, now, in this case, the radiologist was me, and I feel bad about this case. It's an old analog case, happened in the year 2000. My technologist was taking down the case. We did this. We looked at this cancer. The woman was right there. We did the ultrasound. I was getting ready to do the biopsy, 30 minutes later. And the technologist who was working with me, she looks at the case and she says, Dr. Yu, did you notice this on the other side? My heart skipped a beat and I got, a metal taste, garlic metal in my mouth, and the hair on the back of my neck stood up. And I'm like, holy crap, I missed this cancer. There's something on the other side. We worked it. It was second cancer. The important thing is involve your techs. There's a lot of technologists where the doctor is very mean. The doctor yells and screams, don't do that, don't do it. And the technologists are afraid to come and talk to that doctor. Don't be like that, okay? I told this technologist, this was the first time it happened to me, 99, 2000, long time ago. And I said, man, go take your husband to dinner, any restaurant you want, anywhere in Dallas, and bring me the receipt, bring me the cash to the ticket. And I'll send you and your husband to dinner, get a nice bottle of wine, if you want to drink wine or whatever, do whatever you want. The point is involve your technologists, involve your ancillary staff, and I tell them now, I tell every technologist, I've done this for 22 years now. If you find a cancer that I missed, not before, if you find a cancer that I missed, I will pay you $100. We'll call the woman back, we'll work it up. If it turns out to be a cancer, because I'll read a screening mammogram, and now the technologists are taking notes. And they're like, hey, did Dr. Yu call this back? Did Dr. Yu call this back? And they come up to me a couple days later and they, hey, did you see this on the mammogram? And every time, usually but twice in my career, 2 times I had to pay it. Once this one, and another one was another case where I missed some small calcifications, and it turned out to be DCIS. So I have a reward out for anybody who misses a cancer that catches a cancer I miss, because who it helps is the woman. It doesn't matter to me. I carry insurance. I can't find a piece of wood hard enough. I haven't been sued in this business, but it might happen one day. But the big thing is I carry insurance if that happens. So it doesn't affect me as much as it affects the woman. Okay, and it's important. But the key on that is don't get tunnel vision. I was worried about that cancer on the right side, and I probably just forgot to read the rest of the mammogram. Okay, so it's called tunnel vision. Some research calls it satisfaction of search. That term is complicated. I mean, tunnel vision is much better. Your vision just goes into a tunnel. You're worried about that breast cancer, and you forget about the rest of the mammogram. It's like this bear going through the woods, okay? You have a bear here and you're tracking the bear so that the bear doesn't come and eat you, right? And attack you. But the bear that's going to eat you is not this bear that's going away. It's this bear in the woods that you don't notice because you got tunnel vision on the other bear. And so you want to make sure you don't get tunnel vision. The other thing you want to know is your statistics. Review your statistics. I shut down my center. We shut down our centers one afternoon a month. And all we just do screens in that afternoon. We don't do diagnostics, but all the doctors get together, all the breast radiologists, and we go over all of the interval cancers. We looked at the previous mammogram, whether it was from our center or another center, whether I did it or another doctor did it. We don't have an ego. We don't sit there and worry about whether we're going to miss something or whatever. We just open up and we talk to each other honestly. Yeah, Mike, I would call this back last year. I'm sorry, or I look at it and say, it's still pretty subtle. I don't know if I would do it. We go over all of our interval cancers. We go over any difficult cases. many of our biopsies, hey, Mike, would you biopsy this? Or Stephanie, would you biopsy this? Or Tim, would you biopsy this? I did a biopsy. You think it was an appropriate thing to do? And we also look at our cancer detection rate, our PPV for biopsy. We also look at our BI-RADS3 conversion rate. I know that the last 157 cases 2 years ago, I called BI-RADS3. 2 of them turned out to be cancer. One was a calcium that I said was probably benign, and the other was a small mass I said probably benign. But in the follow-up of 6 months, nothing bad happened. They were still stage 0 or stage 1 cancers, and nothing bad happened with the woman. But my point is that 2 out of 157 is 98%. So I know that I'm applying BI-RADS3 appropriately. These are some of the things you need to know about your own performance to see if you are doing it appropriately. You can't just say, oh, it's BI-RADS3, 98% chance it's not cancer. That's if Ed Sickles calls it BI-RADS3. But Ed Sickles might look at that same case and say, you're crazy. That's not a BI-RADS3, that's a BI-RADS4. You should do a biopsy or something like that. So you need to know your own statistics to see if you're appropriately applying the categories. So look at the quality images. You have to QA your technologists. On the MLO view, you should see the pectoral muscle coming down at least to the posterior nipple line, okay, just like this. The pec muscle should be convex, not concave. This is pushing out. This is good. If the pec muscle is pushing in, it means the woman is getting all tense and tight, and you're pulling back tissue and you're not seeing enough. So she should be relaxed. That's a relaxed pec muscle. On the CC view, you should see about a third of the time, sorry about that, about a third of the time, you should see pectoralis muscle on the mammograms. And then just keep a mental note about a third of the time on the CC, I'm seeing a hint of pec muscle. And so you know your technologists are doing a good job, okay? If you take a look at this mammogram, the pec muscle is shortchanged, okay? You have to do a technical repeat. Now, the lymph nodes in the axilla are normal in this case, okay? But you don't get a chance to say that they're normal if you don't get a chance to see them. This is an inadequate pec muscle. This is a bad study, okay? Look at this study, okay? This is the right breast, this is left breast. Is the pectoralis muscle good enough down here? I said, if it was a Monday, I would let this go, but it was a Wednesday. So I said, you know what? We need to get a technical repeat in this study. This is an analog study from maybe 1999 or 2000, a long time ago, but it's the first case that it happened to me. We get a repeat, technical repeat, and there's a little tiny cancer sitting over here on the edge. And that cancer would have just not been noticed, and it would sit there and be cooking for another year, and then it would get bigger and bigger and bigger, and maybe it would be 6 months that we see her back because now it's palpable, or maybe a year and now it's 2 or 3 times bigger. And so you've got to do the appropriate studies, okay? And you have to do a technical recall. This will never happen again. You can go for 20 years and you can do technical recalls on all of these films, and it will never happen again. The woman will drive around the parking lot 3 times looking for a parking space, or she'll get a door ding, and then she'll be frustrated that she had to come back and take another day off when she has so much else going on to come back and get something that should have been done right the first time. So I tell my techs, don't make me do a technical recall because I'm never going to see anything. But you have to do it. You'll never see anything again until June of 2018 when our technologists, and I looked at this and I said, oh man, now we got to call the woman back again and we're not going to see anything. And lo and behold, we do a technical recall. And what do we see on the edge? A little breast cancer right over there, June 18, okay? So I tell my techs, don't make me do a tech call because we'll never see anything until June of 2018, and we saw something. The other thing is blur. Sometimes you get fuzzy mammograms because you have either artifact from compression or from motion or from breathing, the patient's breathing or something. So I was checking out this. This is at the med school in Dallas. And we were working up, I was working with a resident looking at this. And I looked at the right breast. I said, you know, it's kind of fuzzy there. I think that there's some blur, some motion artifact or something. We need to repeat the right breast. And she's here already. So we'll just go ahead and repeat it. We repeat the right breast. Lo and behold, what shows up? This is the original image, okay? You don't see anything over here. It's blurry. We repeat it and look what shows up. This little grouping of calcification. Okay, so this is before and this is after. This is the blurry motion artifact. They're buried in here, but you don't really see them. Now you see them nice and clear. She had an invasive cancer on the left and she had DCIS on the right, but we were able, and it was high grade, we were able to take care of it at the same time and not have to wait 1 year or 2 years or whatever for the high-grade DCIS to become invasive cancer on the other side, okay? So, analysis or paralysis. Start with the report. I see reports, we're a referral center, so if we see reports that come from the outside, and I can read this report and I can tell the radiologist is scared. He or she is paralyzed with fear about doing mammography. Doesn't want to be in the mammo clinic that day, but he got stuck doing it because it was his turn or something, and he didn't really want to be there. And I look at some of these reports, and look at this report. This is I typed it verbatim, no commas, periods, or anything. There is a spiculated appearing mass approximately, not change with compression. To see on the MLO and ML views, this is most likely a recurrent carcinoma. Okay, so you know, and he goes through questionable calcifications, goes the previous study of 13th of January. At the end, he says BI-RADS 3 needs additional short-term interval follow-up after a PET scan is done. The study is suspicious for malignancy of a recurrent nature for which a PET scan is a study of choice. I don't understand this. I mean, is it a mass or is it an asymmetry if you see it on one view or not the other view? Where are the calcs? Is it the same breast or different? What's their morphology? MAG views for calciation, the adenopathy right or left. What is the rationale for BI-RADS 3 is probably benign, but you're worried about cancer of recurrent nature? What this report tells me is this guy's a nuclear medicine doctor and he got stuck doing mammo that day. But by God, he knew if he had a PET scan, he could solve this problem. And, you know, so you have to go back and look and think about the report. And the same thing on this report. This came in more recently. Findings. There is indeterminate mass in the left breast. What good is that? Come on, we can do better than that. I mean, is it medial or lateral? Is it superior or inferior? How big is it? How far from the nipple is it? You know, this came in as a report from an outside study with no mammograms. I didn't even have the mammograms to look. And I'm like, well, this doesn't do me any good. No circles on the films, no nothing. You've got to do better. So what I sit there and say, sometimes you might get paralyzed here and you have to do mammography. When that happens and you see a finding and you're not sure what to do, close your eyes, take a deep breath and just say, okay, describe it. Size, location, distance from the nipple. For distance for the nipple, I like anterior, middle, or posterior depth because that correlates more with sonograms. A lot of times a mammogram and sonogram don't correlate with distance from the nipple because when the woman you're doing a sonogram, her breast is compressed against the chest laying on her back, but on mammogram, she's up and everything is pulled forward. So nonetheless, if it's a mass or distortion, so the first thing I tell the residents to do, just take a deep breath, close your eyes, size, location, distance from the nipple. Now, if we go back to that other mammogram about an indeterminate mass in the left breast, if I said there is a new 1 centimeter mass on the 2 o'clock axis of the left breast at middle depth, partially circumscribed. You have now a picture in your brain of what's going on. You know, there's a 1 centimeter partially circumscribed mass on the 2 o'clock axis of the left breast at middle depth. Boom. you know exactly what's going on. You can look at the mammograms, you can figure it out, and you can know where to focus your ultrasound, things like that. For a mass, the most important thing are margins. Margins, density, and then secondary signs. Is it spiculated? Is it circumscribed? Is it obscured or indistinct? Things like that. For calcium, the two most important things to me are morphology and distribution. What do they look like? Where are they located? I like to have standard workups. I know we're getting short on time and I want to save time for questions, but have some kind of, we have standard workups in our center for a mass, for calcium, for asymmetry, if it's seen on the MLO or the CC view. I'm not going to go through this, but I can send Reem my handout for the talk, and you guys are welcome to have, oh, it's recorded also. So you're going through the recording. Tangential views, anterior, miscellaneous. So we have a standard workup, but I want to make sure I get through. Diagnosis is not just mammography. It's a comprehensive evaluation and requires other imaging. I always do a physical exam on all of my diagnostics, almost always, to correlate the physical exam. I want to know, this woman comes in, Mrs. Smith. Where do you feel the lump? Put your finger on it. Show me. So I make sure that I'm evaluating the same concern that you have. Okay. And I go in myself to make sure I do the clinical correlation. I like to use ultrasound. I like to use lots of it. It may, clinical correlation may be the most difficult thing we do because we are accepting a tremendous amount of responsibility, right? But who's in the best position to do it? We have the tools, the technology, and we have the expertise to do it. A family doctor can't read our report and say clinical correlation suggested about your palpable mass that I didn't even look at. We're in the best position to do it. We should accept that responsibility to do it. Okay, but I think the most powerful tool of all, especially in the diagnostic clinic where you're evaluating a lump or a mass on a mammogram or calcium, talk to the patient, show her studies, go over the films. Don't throw stones. Don't talk about how bad some other doctor might have done. Just focus on what the problem is and take care of the woman. Because this is a study that came into my center and one of my colleagues read it in May. This was years ago. It's an analog study. But he said, this is a simple cyst. If it bothers you, we can drain it. If not, come back in a year. Well, the woman, I don't have the sonogram from that day. It was lost, analog film. But I know my previous partner. He was an excellent radiologist. There's no doubt in my mind that he thought this was a cyst last year. So I'm working between Christmas and New Year's in December. And this is now, she comes in and says, the cyst is bigger. I want you to drain it. Well, again, my heart skipped a beat. I get a garlic or metal taste in my mouth. The hair on the back of my neck stands up. I know this is not a cyst. And I do the ultrasound, and then I have to talk to her. And I go over the studies and I say, this is not a cyst. It's something that's, we need to do a biopsy. And I go over her films and she says, what about 6 months ago when you told me it was a cyst? And the only thing I could do was look her right in the eye and say, I think we made a mistake and I'm sorry. But if you let me take care of you, I will take care of you. If you want me to find another doctor for you, I can understand that. I will help you find another doctor. I would send a family member to, but I will be, if you let me be your doctor, I will take care of you. We'll do a needle biopsy and we'll take it one step at a time. And she does. She lets me take care of her. She goes. So I sell these practices. I'm not in Dallas. I'm at the medical school, take over as director. A year later, I get a phone call from the front desk. Mrs. Smith is on the line, and I recognized her name. She said, hey, Dr. Ulysses, you left your center here just a few miles away, and you're at the med school. I want to come see you at the med school because you told me you would be my doctor and you would take care of me, and I'm holding you to it. And I said, sure, of course, come on in. And I continued to take care of her. So again, my point is, if you talk to patients and you're honest with them, they will be much more understanding than if you try to hide something. We may not be the primary physician. We may not be the primary doctor, but there's nothing secondary about what we do, okay? It's an important job and we should treat it as such. It's an attorney bringing you a set of films. What's the most important thing we do? Screening mammography. Stay focused, make it a comprehensive approach. This is not my approach to mammography, okay, to a mammogram. I was helping defend a doctor. There was another doctor being sued, and there was a radiologist said this was an obvious cancer. And I was saying it's obviously not. I don't think it was subtle. It was fine. I think the doctor did a good job. So in the trial testimony, the attorney asked the other radiologist, "Doctor, you've missed a cancer in your career. You've been a doctor for 23 years. You've certainly missed a cancer." She said, "No, I've never missed a cancer. I've been reading mammograms for 23 years. I've never missed a cancer in my whole career." The attorney was so shocked. I was shocked. He said, "I'll ask you again. You yourself have never missed a cancer that you're aware of?" "No, I don't think I have." I'm not saying that this other doctor was lying. I think that if you are so convinced that you're the best doctor in the world, that in your 23-year career, you have never missed a cancer, it doesn't leave you with the right frame of mind to go back and look at last year's study, to see if you could have done a better job, to see what could be better for the woman. Because I can tell you, if at the end of my 23-year career, if I think I'm no better then than I was when I started, I'll be more disappointed with that than with any cancer that I've ever missed. You have to get better over time. And the only way to get better is to go into your brain and see what you could have done as a better job from 1 year ago or 2 years ago or 6 months ago. And if you think you've never missed a cancer, then I think that's probably bad, because we're going to end on this. This is a left CC mammogram. A lot of people see benign calcium, but I see a bunny rabbit, Aranama, right? This is the ears, the head, the eye, the mouth. And I tell people there's more art than there is science sometimes.
Give you access to open your mic. We can give you access to open your mic and ask your question directly to Dr. Mike if you raised your hand. I just want to remind you that this is a series of webinars that started today, and they will continue for 5 consecutive days from September 18th to 22nd, and CME hours will apply. These webinars serve as an introduction for our conference in 2022. We will announce more details about and information about how to register and participation early 2022, and we're looking forward to having you with us next year. Dr. Mike?
I have my fingers crossed. I hope that we can do it next year in person. That would be much better.
We hope so.
I have a couple questions. One is, my mammogram missed a cancer on my regular visit. 42-year-old woman. Ultrasound was not definitive, only the MRI detected. MRI is a must for women after 40. Well, we use MRI a lot in the United States. We use it definitely for screening for high-risk women. If you have risk factors greater than 20% on one of the standardized models, like Tyrer-Cuzick, BRCA Pro, something like that. I'm thinking maybe you had dense breast tissue and it was difficult to see on the dense breast tissue, and MRI showed it. I don't use MRI for average risk women in the United States. I agree. It's an excellent study. It's probably the best we have to pick up a small cancer. But if you use an average risk women, it only helps maybe 2 or 3 in 1,000. And so I have to look at what we're doing for society and for healthcare and where we're spending our money. But if you use it on high risk women, it helps much more, maybe 9, 10, 11 in 100. And so that's why we use it on high risk women. We are experimenting with ways to maybe do a fast post-contrast MRI. It might only cost $250. We can do it once every 2 or 3 years and use that as a screening test for women. We're looking at diffusion weighted imaging. We're not there at the United States to use it on every woman over 40, It is a good study, and we're working on it. Another one, why do you like to do ultrasound? Ultrasound has many advantages. One is you can characterize the mass. I mean, you can tell if it's a simple cyst or if it's something that needs to be biopsied. Plus, if you do a biopsy by ultrasound, it's much easier than if you do it by stereotactic. So sometimes I'll see calcium, and these are aggressive calcifications. It's in a big enough area on the mammogram that I'm going to see this with ultrasound. I don't do the ultrasound to characterize the calcium. I do it because it's an easier way to do a biopsy for that woman, and I do the biopsy that way. Also, ultrasound, this is a whole nother talk. I can give you a talk on ultrasound and the role, masses and the role of ultrasound and why we do it on masses or calcifications. But, you know, it's easier for the woman to get a biopsy with the ultrasound, and with the calcifications, I can see the footprint of the calcifications with the ultrasound, so I can use it to target my ultrasound, my biopsy with ultrasound instead of mammography. Okay. Who trains your techs to improve the quality? If we come in 2022, Ozma and Reem have already agreed to allow us to bring some technologists that will specifically train you guys with your technologists there, and with one or two of our technologists. We're going to have a whole technologist workshop on positioning. It'll last for several hours and make them better. But we train them. Either the doctor trains them, or we have technologists who are geared to who are designed to train them in the United States. And you do need training. And I hope that we can do that workshop, that we can come in 2022 and do that technologist training workshop. It's an excellent one. Do you recommend doing tomosynthesis for screening? Yes. In fact, I think it's more important for screening than for, well, it's important for both, but it's really important for screening because, again, that's where we're going to find that small 1 centimeter cancer or distortion, architectural distortion, something like that with tomosynthesis. The radiation dose is a little bit more, but not that much more than 2D, even with the combined dose. But now that there are things called C-view, and that's one vendor calls it C-view, but basically you can do only the tomosynthesis images, and then you can use to reconstruct 2D mammogram backwards, and it's almost as good a mammogram. It is as good in terms of our research, and so we like doing that. What information you gather for high-risk patients? Boy, that's a whole nother talk. But basically, we put them through. We use the IBIS, the Tyrer-Cuzick model. We have an iPad. They show up, they fill in the iPad with all of their family history, their previous biopsies, if they had atypia or LCIS, or just all the information on the iPad. That goes into the computer program that calculates her risk factor. We do that for every patient who shows up at the door. Mammogram, ultrasound, of screening, diagnostics, coming from another center. We do it for every patient. Opinion on elastography. It has not gained a lot of traction. And I've used it. My machine has elastography. It doesn't change my management very often because, again, if I look at something and I say, okay, I use elastography, and I tell the woman, oh, with elastography, I'm a little more convinced that this is probably benign, and I downgrade it from a 4A to a 3, okay? She still has to either do a biopsy or 6-month follow-up, and psychologically, what does that do for her? I say, well, I'm a little more confident that it's probably benign. I don't know. A biopsy is nothing. It's not even as bad as going to the dentist for a filling. You give some numbing medicine, you put a little tiny 16 or 14 gauge needle in there, you take some pieces off, the laboratory looks under the microscope, they tell you 100%. So I either, I call things BI-RADS 3, and I tell them, yeah, this is probably benign. I'm happy to do 6 months. I'm going to sleep fine for 6 months. If you're not, we'll do a biopsy, and many women do that. But adding elastography has not changed, in my experience, my management, maybe on 1 or 2 cases, and not really, but not enough to convince the woman not to come back in a year. You perform ultrasound on all normal appearing mammograms. So I would like to. I don't in the United States because there is the woman either has to pay for, we don't have an insurance system in the United States. We got crazy medicine in the United States sometimes. I think it's nuts. But anyway, we don't have an insurance system where I can just do this on every woman. However, for dense breast tissue, ultrasound is an effective way. I can give you a talk next time on the rationale for screening ultrasound. I will probably do it in March of 2020 or in October 2022. Probably be one of my talks that we give there, or Dr. Rapelier will give it, one of us. It's a useful study. Yeah, if you guys can do it on dense breasted women and you get an A-bus machine, I think it's worth it. When is suspicion better to ask for MRI or a biopsy? I think a biopsy is better because, again, MRI is a complicated, expensive test. In the United States, you have to go to a specialized center. Well, mine is a specialized center. But I also, if I'm worried about something enough, I won't use an MRI to make me not do a biopsy, except in rare cases. So generally, I'll do the ultrasound biopsy or the stereotactic biopsy. But occasionally, I do use MRI for problem solving. Maybe I have this vague area on the mammogram. It looks pretty much okay, but I'm not 100% sure, but I can't, it's not enough to give me a target for a stereo biopsy. The ultrasound doesn't show anything. I feel this lumpy, bumpy tissue on my physical exam, and I'm not 100% sure. So then I'll do an MRI, because if the MRI is normal, the negative predictive value of an MRI is super high. I mean, it's almost 99%. It probably, in the right hands, it's 99%. It's a really good negative predictive value. So I think it's good. I'll do it occasionally. I'm a breast surgeon. Can I do breast ultrasound for patients during follow-up visits? What's your advice? Well, in the United States, there's a certification problem for breast surgeons to be certified in breast sonography. I don't mind. I help breast surgeons all the time, and I'm happy to teach them to do follow-up ultrasound. You have to feel confident that you're capable, that you're able to make the right diagnosis. But if you can feel the lump and you put the transducer right there and the tissue looks totally normal, in my mind, I feel comfortable calling it normal. But I don't know your experience and your expertise as a breast surgeon. But I don't have any problem with breast surgeons using sonography in their office. You have to decide what level and keep track of your statistics, of your data. How often were you wrong? That's the big thing, is feeling confident. And then if you need help, like I say, I've helped breast surgeons train in breast sonography. When I ran the cancer center, we had breast surgeons come through all the time for training. So anyway, what is better to do, screening with 2D or I like 3D? I like doing screening. I think it should be done on use 3D on all screens. Yeah, how much medical students should know about mammography and how to read them? Medical student, I think the biggest thing is to go through the rotations to see what you want to do in your career. Do you want to do radiology? Do you want to do OBGYN? Do you want to do pediatrics? Or do you want to do, surgery, that kind of stuff? I don't know that you need to know as a medical student how to read a mammogram. Now, I also don't know the medical situation in Jordan. I worked in Africa for 6 years, Angola, Zaire. We were in the middle of the jungles. A medical student there could probably do a lot of good with an ultrasound machine, and we didn't have mammograms out there, but with a portable ultrasound machine. So it depends on the situation, but in general, I think medical students should use the rotations and the training to get basic training on what mammography is, how we interpret it, how we do the ultrasound, how we do the clinical correlation. But I don't think you need to be trained as a medical student to be able to interpret mammograms or interpret ultrasound or do biopsies. I don't have medical students doing biopsies in my centers at the med school in Dallas. So just the residents and fellows. And residents only after they've completed one full rotation and they've done a lot on chicken breasts or turkey breasts. Anyway, is there a role for contrast? Yeah, there is a role, especially if you don't have an MRI machine handy. Of course, you're giving iodinated contrast, a little more complications. But yeah, the data show it's a good study, contrast mammography. I don't know if I'd be doing it in everybody for screening and all, because, again, you're giving contrast to everybody. But if you didn't have an MRI, if you in a diagnostic setting, sure, I think it's great. At what age to start screening, looking for controversies and guidelines? Yeah, there's probably political stuff too. For me, I like to educate women on nice, round, easy numbers. I say 40 to 80 generally every year. However, I also know the data and I have a lot of experience. If after the age of 60, you wanted to do every other year, it would not bother me. This idea about 45, 50, 55, I can give you another lecture on the rationale for screening mammography. There's nothing magical about the age of 50. It's not premenopausal or postmenopausal. If you look at the curves, the NIH data, breast cancer risk goes up after the age of 40, really 38, 39, the curve starts to go up, and it goes up at a pretty steady rate until about the age of 78, 75 to 78, where it starts dropping down. So I like to pick nice round numbers for women to remember. Do it the month of your birthday or something like that. 40 to 80 every year. Over 80, I start to have heartburn doing mammograms, because that woman is, even if she gets breast cancer at the age of 83, she's probably going to die with it, not from it. 45 to 50, this gray zone. I think a lot of it just ends up being, there's probably some element of politics or something in that. I don't know. I think that, but I would do them every year, at least until the age of 60. Because of my experience. I've probably read over 300,000 mammograms in my career between screens and diagnostics. And so I've seen a lot. Anyway, those are my 2 cents. I need to do it self rather than a radiologist. Was that the surgeon? Yeah, surgeons. I've trained surgeons to do the sonograms themselves. You just have to keep your data, keep your statistics. And there are some radiologists who don't feel comfortable doing sonography. They let the techs go in and do it. They don't even do it themselves. I train every doctor at the med school and residency and fellowship to do the study themselves. If you're a practicing surgeon, you feel comfortable doing sonography, go ahead. Keep your data, keep your statistics. In the United States, you would get certified. You would go to a breast surgeon's ultrasound certification program, and you would get certified to do it. And then sure, you can do it and do the biopsies. It doesn't bother me. There's plenty of business for all of us in the United States anyway. In young high-risk patients, how early to start screening baselines? We'll generally start breast MRI around the age of 25. If they're BRCA or some other high-risk factors, we'll do breast MRI starting around the age of 25. Generally, they say get a mammogram 10 years earlier than the age of the first-degree relative. So if her mom got diagnosed with breast cancer at 45, I'd start mammograms at 35, down to the age of about 25. But MRI, if I had to pick a test in the high-risk women, a lot of times we're doing MRI only until they get to be about 35. And if the serial MRI 2 or 3 years in a row, they're normal, we can start skipping years on an MRI. It's a really powerful study. We're still looking at a lot of different ways to do it with research and which way is the best, but definitely MRI is good. And for mammograms, 10 years earlier than the youngest first-degree relative. Is there any relation between family history and mammography reading? I'm not sure what that question is, but 75% of women who get breast cancer have no family history. So to say that, you don't have any family history, so you don't need a mammogram, does not make sense. You still need a mammogram. If the woman has had a mom who got breast cancer at the age of 35, am I worried more about reading the mammogram? Yeah, I mean, for sure, the MRI is going to be really definitive though. So if the MRI is normal, I feel really good about that, even if she's high risk. Does BMI have a role? Yeah, it does have a role. BMI is important. Overweight women, obese women, absolutely. You have more fats circulating in your body, probably binding estrogens more, stimulating breast tissue more. Yes, and it's part of the risk assessment models. Do you perform 3D tomo with digital mammo combo or on all? Yeah, I do it on all screens, and we do the combo. Our machine doesn't do C view. So if I had a machine that did C view, I would use it because it is a lower radiation dose. But yes, I do it on all screens. Okay. I guess that's about it.
We have more questions, Doctor, for the people who are raising their hands. We will now give you access to open your mics and ask your questions directly. But Dr. Mike, maybe there's just one extra question that maybe you did not answer. A breast surgeon is asking, do you have any advice for a breast surgeon practicing in poor mammogram reporting center as they are trying to do breast conservative surgeries?
Heavily would not recommend a breast. Now, using the mammogram that's read and using it for correlation, yeah, as a breast surgeon, you might find something that a radiologist missed. But in general, in my experience, if you are doing as a breast surgeon the definitive reads in mammography, I would stay away from that. I don't think that's a good idea. Doing ultrasound as a breast surgeon, you go to a program where you do enough ultrasounds and you get certified to do breast ultrasound. I have no problem with that. That's fine. But reading the mammogram as the primary reader as a breast surgeon, I would say no. I would not recommend doing that. Again, I don't know the situation in Jordan, but those are my thoughts. Did I answer the question?
I think yes.
Okay.
Because we have also other questions like what is the use of doing yearly mammogram if cancers are missed? The mammogram should be interpreted by a group of physicians, not only one, and physicians should be trained regularly on how to read the mammogram. I think the two questions relate to each other's.
Are you talking about double reading maybe?
Sorry?
Are you talking about double reading? Is that the thrust of the question? I don't see the question. Is it on a chat? Oh, there's chat. Oh, wow.
I think this is more of a comment rather than a question itself, and it relates to the previous question. I think we should continue to invest in training radiologists and radiographers and doing good mammograms and reading mammograms rather than stopping doing mammograms or to be read by different specialists.
Oh, so, I agree with that 100%. Yes.
If we're doing something wrong, that does not mean to stop it. We should continue to do it and try our best to do it in the right way. I think, Doctor, we Absolutely. Can move to the people who are raising their hands. So Dr. Rabab, Dr. Muhammad, and Dr. Dima, Dr. Hani, you will be given the access in order to ask your questions.
So what is the advice of a breast surgeon practicing in a poor mammography reading section? Yeah, you have to get trained radiologists. You really do. I don't know. I can't answer that question, but I have seen a situation in the United States where the breast surgeon was much better than the radiologist reading the mammogram, and we shut down that center. I used to be one of the reviewers and things like that in the National Society. Okay. But anyway, you need to get trained. You need to train. I think it's more important to get trained breast imaging people doing high quality reads than it is to have other doctors like OB-GYNs or surgeons be the primary reader of the mammogram.
Okay.
That's my thought.
Doctor, we have Dr. Muhammad Athamne. He wants to ask. Dr. Muhammad.
Yes. Yes. Thank you. Thank you, Reem. Thank you, Dr. Mike. I'm a breast surgeon, and this is the actual situation, not a virtual situation, in a very poor reporting area of mammograms. We are trying to implement, as surgeons, we are trying to implement conservative surgery. So what's your advice in this situation? Poor reporting of mammograms. What is
you want to do breast conservation surgery, but you don't have good mammography or breast imaging support. Is that correct?
Yes, exactly. Exactly. Yeah. This is the situation.
I have not I've not encountered that, so that's really difficult. What about breast MRI? If you want to do so, when you have a diagnosis of breast cancer, because the woman felt a lump and you did an ultrasound biopsy, maybe you get a diagnosis of cancer. Can you do an MRI on every one of your cancer diagnoses?
Of course not. Of course not. You cannot do MRI for every patient diagnosed with cancer. But if they can't read mammogram, probably they won't be. Of course, they won't be able to read MRI. And MRI is more complicated.
You can probably read an MRI more easily than you can read a mammogram. That's my personal thought from doing this for 25 years. You can
you suggest
an MRI.
You suggest doing MRI for let's say prospective potential conservative management patients.
Yes, I would. Because in your situation, you're not getting good breast imaging support, and if you're wanting to do breast conservation but you're not sure about the tumor size, about multifocal, multicentric,
exactly, multifocal, multicentric, yes.
Breast, I'm pretty sure that you can read an MRI better than you can read a mammogram. Okay, I don't know for sure. I don't know you.
Yes.
But an MRI is not hard to read. There are some subtleties. But in general, I will bet after you've read 50 MRIs, you'll be pretty darn good at reading breast MRI. If you've read 50 mammograms, I don't think that would be the same. I really don't. But
so you suggest MRI as a substitute?
Yeah, in your case, if you're thinking of breast conservation in a newly diagnosed breast cancer patient, I would do a breast MRI, and I think you might not get good support. Let the radiologist try to read it, but you can overread it and do, I think, a fine job. Okay, and there are So anyway. I wonder if it's worth coming up with a program for places where you can get second opinions from quality centers in Europe or the United States. It's so easy to send images like mammograms, ultrasounds, MRIs to other places in the world. We could even probably come up with a way to get second opinions or something like that for you from places in the United States or Europe that do nothing but breast imaging. And that might help you.
As a program doctor, we are activating the double reading policy currently in Jordan.
Yeah.
So we are in the process of doing something like this, but for radiologists, for Jordanian radiologists between each others.
Yeah, a double reading program shows a benefit. We also showed that CAD can help in the United States. So we don't generally do double reading in the United States. I don't know anyone that does, but a lot of that is because of the resources. And the charge to the woman. Anyway, double reading is good. I'd start with that for the radiologists.
We will go now with Dr. Rabab Al-Hassan. So Dr. Rabab, you can now open your mic. Dr. Rabab, can you please unmute yourself?
Well, while he or she is trying to do that, why don't you go to another doctor and then
I think she unmuted herself. Dr. Rabab, please go ahead. Okay, so we can move to Dr. Dima Ahmed. Dr. Dima, please unmute yourself.
Yeah, you're still on mute, Dr. Dima. I can see that. Lower left part of your screen is a button that says unmute. It'll be on your screen lower left. I don't know.
Dr. Dima Ahmed, can you unmute yourself?
I have to leave 5 minutes, unfortunately, because I have another meeting at 10
That's
o'clock
okay.
at another facility.
So by this, if no one else have any other questions, we will end. We will thank Dr. Mike Ulysses. Dr. Mike, thank you very much on behalf of all of the Jordan Breast Cancer team. Yes, go
Real
ahead.
quickly, if you get these other doctors, you can send me the questions on email. You can give anybody my email. I'll answer their stavros.
Okay, that's great. I just want to also remind you tomorrow at 6 p.m. we will start with Dr. Tom Stavros. He will talk
Awesome.
about ultrasound. Dr. Tom is a fellow of the American College of Radiology and a fellow of the Society of Radiologists in Ultrasound and a fellow of the Royal Australian and New Zealand College of Radiology. His session will be tomorrow at 6 p.m. Looking forward to see you all again. Thank you very much. And thank you, Dr. Mike. And until we see you in 2020, hopefully, I wish you all the best. Thank you.
بأمان الله.
بأمان الله. شكرا.